Hi and welcome to this video on aggressive B-cell lymphomas. This is aimed at Haematology Registrars revising for the FRCAPTH, and it will cover DLBCL, primary mediastinal lymphoma, primary CNS lymphoma, and HIV-related lymphoma. We'll go through the workup needed, the IPS prognostic scoring system, treatment in early and advanced stage lymphoma, as well as double hit treatment and the evidence behind CNS prophylaxis. So like any other type of blood cell, B cells originates from hematopoietic stem cells in the bone marrow. The immature B cells then migrate from the bone marrow into the lymph nodes. In the germinal center, it undergoes somatic hypermutation as the B cells are exposed to antigens from antigen-presenting cells, and then they are selected and they become memory B cells or plasma cells in the activated B zone. Immature B lymphocyte stage in the bone marrow can give rise to B lymphoblastic lymphoma or leukemia. Pre-germinal cell compartment can give rise to mantle cell lymphoma and sometimes CLL. The germinal center is where we see follicular lymphoma, Burkitt's lymphoma, and sometimes DLBCL and Hodgkin's lymphoma. Post-germinal center neoplasms include marginal zone and MALT lymphomas. The clinical presentation can happen very quickly with enlargement of the lymph nodes, development of hepatosplenomegaly, invasion into the extranodal sites causing superior vena cava obstruction. Cytopenias occur when the bone marrow is involved or in an autoimmune phenomenon. Infections from neutropenia, fatigue from anemia, and bleeding and petechiae from thrombocytopenia. B symptoms such as fever, weight loss, pruritus, and night sweats from cytokine release, and paraneoplastic syndromes such as nephrotic and hemolytic anemia and ITP can also occur. It's important when you see a patient in clinic or when you see them in A&E that you cover a history of chronic infections like HIV, hepatitis C, H. pylori, which can also predispose to lymphoma, as well as needing to be treated at the same time as lymphoma. Immunosuppression from autoimmune diseases or post-transplant can also predispose to lymphoma. It's also important to look for lymphadenopathy as well as hepatosplenomegaly on examination. So when we think about the mutations involved in aggressive B-cell lymphomas, there's issues with the receptor cell signaling, so issues with CD79A, 79B, lymphocyte differentiation, which is the MYD88 mutation, lymphocyte activation, which is the TRAF3 mutations, chromatin modifications resulting in KMT2D mutations, or immune surveillance by B and T cells with beta-2 microglobulin and CD58 mutations, or DNA repair abilities with TP53 mutations. But unlike AML, there are no lymphoma-defining genetic abnormalities, but the WHO 5 2022 classification names a number of different types of lymphoma. Some of them can be grouped into specific gene abnormalities, so DLBCL or high-grade B-cell with MYC and BCL2, which is double-hit lymphoma, or RF4 mutations or ALK positive mutations, or specific clinical locations like primary mediastinal or large B-cell of immune-privileged sites like CNS or the testes, or lymphoma to do with viruses such as EBV positive DLBCL or HHV8 positive lymphoproliferative disease. And others can be classified into types that have a distinctive morphology like T-cell histiocyte-rich lympho, large B-cell lymphoma, or plasmablastic lymphoma. So when working up patients with DLBCL, an excisional biopsy is preferred. A core biopsy is acceptable when surgical approach is impractical or is too risky. And then when you've got the tissue diagnosis, you need immunohistochemistry, and there will be a light chain restriction kappa or lambda present, and PAX5 is also expressed by DLBCL. On flow cytometry, DLBCL are CD45 positive, and express the pan B cell marker CD19, CD20, CD22, and CD79A. CD10 is usually present, though CD5 is only seen in de novo cases. Then FISH for a MYC translocation and its IgG partner is useful for prognostic purposes. FISH for BCL2 and BCL6 translocation is also looked for if the MYC is rearranged. Then you'd need baseline tests for like FBC, looking for any cytopenias, so suggestive of bone marrow involvement or autoimmune issues like hemolytic anemia. You will need to look at the blood film as well as looking at renal function and electrolytes for tumor lysis bloods, serological testing for hepatitis B, including core antibody hepatitis C and HIV, should be routinely performed because it can be associated with lymphoma and they need to be treated at the same time. People with HIV that's fully controlled with a fully suppressed viral load and a CD4 count above 200 can be treated on the same protocol as patients who are HIV negative. If there's a suspicion of CNS disease based on symptoms, then you would need to do an MRI as well as a baseline CSF, including cytology and immunophenotyping on the CSF. It's important to also record the ECOG performance status and the IPI and CNS IPI scores for all the patients. So this diagram shows the pathological expression of the cell receptors, which are detectable by immunohistochemistry, but also new drug targets. So CD30 is targetable by brentuximab, CD79B is targetable by pelentozumab, which we'll be talking about shortly, as well as CD5, which can be targetable by ibrutinib. The International Prognostic Index score is calculated on diagnosis, so you get a score of 1 for age over 60 if the LDH is high, the Ann Arbor stage is more than 3, there's more than 2 extranodal sites. So if you get a score between 0 and 1, you're lower risk, with an overall survival at 3 years of around 91%. If you're scoring between 4 and 5, you're higher risk, and therefore you have an overall survival of around 59%. Other prognostic factors to take into account would be the bulk of the disease, so if it's more than 77.5 centimeters, or if the patient has double hit cytogenetics, so with MYC and BCL2 translocations, as well as the cell of origin, so if it was germinal center, it's better prognosis than activated B cell. This can be determined on immunohistochemistry as a rough estimate. And in studies, there's been a number of gene expression profiling subcategories of trying to subtype DLBCL. However, it's not clinically used in UK practice outside of clinical trials and research. So what do you do about treatment? For patients between 18 and 60 with stage 1 and 2, so early stage disease, with the IPI score of 0 without any bulky disease, you can offer them abbreviated chemoimmunotherapy, so 4 cycles of R-CHOP plus 2 additional infusions of rituximab. Radiotherapy is not required if full dose intensity is delivered with the chemo, as there's not much evidence supporting improved outcomes with it. For patients between ages of 61 to 80 with stage 1 and 2 disease, so early disease, again with the IPI score of 0 without any bulky disease, you might consider a PET adapted approach. So if you perform an interim PET-2 after 2 initial cycles of R-CHOP, and if the patient's in complete remission, which is a doable score of 1 to 3, you can complete their treatment with a further 2 cycles of R-CHOP. If the interim PET does not achieve complete metabolic response, then you would deliver 4 further cycles of R-CHOP followed by radiotherapy consolidation of 30 guy in 15 fractions. For other patients less than 80 years with stage 1-2 disease but a higher IPI score, so at least 1, you could consider combining modality with 3 or 4 cycles of R-CHOP with radiotherapy. You'd consider 6 cycles of R-CHOP without radiotherapy where the risks of radiation are considered to be greater than 2 or 3 further cycles of R-CHOP. For patients less than 80, again with early stage disease, but a higher IPI score of more than 2, you can give them 6 cycles of polar R-CHOP, which has now been approved first-line therapy for this disease category following the POLARIX study. On top of this, you may want to consider radiotherapy for patients who have had mini CHOP because of comorbidities and frailty, or if they have extranodal involvement, or if they have bulky disease. In addition to chemotherapy, it's important to think about the patient's risk of osteoporotic bone fractures. The cumulative incidence of frailty-related fractures was 11% in a recent UK study in large B-cell lymphoma patients above the age of 70, as well as having osteopenia or prior fractures or rheumatoid arthritis, or bony involvement of the lymphoma, or having pre-phase corticosteroids were all independent risk factors for osteoporosis. So baseline osteoporosis risk with a FRAC score should be calculated, as well as supporting patients on high dose steroid therapy with a vitamin D treatment and bisphosphonates. Patients are also at higher risk of infection, like we know for chemotherapy, so GCSF is needed for neutropenia, as well as acyclovir and cotrimoxazole. So primary extranodal large B-cell lymphoma can happen in a few places. It can happen in the breast, it can happen in the stomach, it can happen in the testes, or intraluminally, or in the skin. Most patients with primary extranodal large B-cell lymphoma have a low IPI score. However, those with an IPI score between 2 and 5 were eligible for polar R-CHOP on the POLARIX trial, so there is an option for this patient group. With a lower IPI score, you can use R-CHOP, but there is also a high need for CNS prophylaxis, particularly in patients with primary breast large B-cell lymphoma and testicular involvement. Testicular involvement has an inferior clinical outcome compared to other subtypes of extranodal large B-cell, and in particular with a higher risk of CNS relapse. So you treat with 6 to 8 cycles of R-CHOP and 4 doses of intrathecal methotrexate and radiotherapy to the contralateral testes. In breast large B-cell lymphoma, there's high rates of relapse in both the ipsilateral and contralateral breast. As a result, CNS prophylaxis and consolidation and radiotherapy are often considered. Patients with gastric large B-cell lymphoma are generally treated with 6 cycles of R-CHOP. Intravascular large B-cell lymphoma is rare and characterized by neoplastic B-cells within the lumen of the blood vessels. They normally affect older patients and often involve the central nervous system, lungs, and the skin. Prognosis is really poor, although patients with isolated skin lesions appear to do a bit better. Again, 6 cycles of R-CHOP can be offered, as well as CNS prophylaxis, but consider delaying the first rituximab infusion by over 48 hours after chemo. That's to mitigate against the risk of severe infusion reaction in cycle 1. So we've mentioned palantisamab a few times now. What is it? It is an antibody-drug conjugate that targets CD79B. The antibody is a microtubule inhibitor and targets the 79B subunit of the transmembrane. So 6 cycles of polar R-CHOP is now first-line treatment for patients with de novo large B-cell lymphoma who are fit for 4 days chemotherapy with a performance status of less than 2 and an IPI score of around 2 to 5. Therefore more advanced disease, but R-CHOP is still an option for this group and for patients with a lower IPI score of 1 with stage 3 to 4 disease. For younger patients with advanced disease, more dose-intensive regimens like R-CODOX M/R-IVAC are considered for patients with an IPI score of more than 3, particularly for those considered at high risk of CNS relapse. So in the POLARIX study, the palantisamab replaces vincristine because of overlapping toxicity. They both inhibit microtubules. POLARIX was a phase 3 randomized control trial, and the new polar R-CHOP regimen reported an improved 2-year progression-free survival of 76% versus R-CHOP. Eligible patients included had a performance status of 0 to 2 and an IPI score of more than 2, and they were suitable for intensive chemo. So this is now approved first line for this particular class of patients. So what about double hit lymphoma? This means patients with genetic mutations of MYC translocation and BCL2. Double hit doesn't really respond to R-CHOP, and therefore patients need more intensive therapy. And FRCAPTH M/RIVAC or DAR-EPOC have much better outcomes. And some studies have shown that adding a stem cell transplant doesn't make a difference for double hit lymphomas. There's also a 10% risk of CNS relapse. There is no accepted standard of care for patients with high-grade B-cell lymphoma with MYC, BCL2 or BCL6 rearrangements. But the treatment options include pola-R-CHOP for patients with an IPI score of 2 to 5, or 6 cycles of R-CHOP, or for younger patients where MYC is translocated to an IgG or immunoglobulin partner gene and coexists with a BCL2 rearrangement. Intensive regimens like DAR-EPOC or DAR-R-CODOX MRIVAC may be considered. Over half of the patients presenting with DLBCL in the UK are over 70 years old. The Elderly Prognostic Index is useful, which integrates the simplified geriatric assessment, the IPI score, and the hemoglobin levels to define low risk, intermediate risk, and high risk groups, and their 3-year overall survival, and whether it's useful to give them intensive treatment or not. In patients less than 80 years old, evidence suggests that retaining full dose intensity of R-CHOP is important for survival outcomes. However, in those patients who are over the age of 80, there's evidence to suggest equivalent survival between full dose R-CHOP and attenuated R-mini-CHOP. Recent studies show that patients above the age of 80 treated with R-mini-CHOP experience a 2-year overall survival of around 60%. Using a validated FRCAPTH index tool like the EPI can help you inform the risks and benefits of therapy before deciding on treatment. Offering a corticosteroid prephase of 1 mg per kilogram of oral pred in patients whose performance status is adversely affected by large B-cell lymphoma is useful. Adding vincristine to this is also a consideration as a single dose of IV 1 mg. For patients with cardiac comorbidities, you can offer a non-anthracycline-based regimen. The options include RGCVP or RCEOP. Palliative approaches for patients not fit for intense treatment may be rituximab monotherapy or palliative radiotherapy or steroids at best. Primary mediastinal B-cell lymphoma characteristically presents with a bulky anterior mediastinal mass. Differentials of that could be a thymoma, teratoma, thyroid goiter, or lymphoma, and it's generally Hodgkin's lymphoma, primary mediastinal B-cell lymphoma, or T lymphoblastic lymphoma. It invades local structures, and the disease is usually confined to the thoracic cavity. It normally presents in the 3rd or 4th decade, and there's a female predominance. Patients may present with compressive symptoms and features of severe superior vena cava obstruction or effusions, pleural or pericardial. So if there's evidence of SVCO, then appropriate anticoagulation needs to be given to the patient. So 6 cycles of R-CHOP is an appropriate first-line treatment, so rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisolone, and involved site radiotherapy. DAE-POC-R, so dose-adjusted etoposide, prednisolone, vincristine, cyclophosphamide, doxorubicin, and rituximab. 6 cycles without radiotherapy is also an alternative approach, but should be given in centres that are experienced with giving complex chemotherapy. Generally, there's a low incidence of relapse, about 10 to 30% relapse, and a PET scan should be performed at that stage, and you could consider giving radiotherapy if you omitted it during the initial therapy. The choice of salvage chemotherapy should be the same as DLBCL with consolidation or autologous stem cell transplant, but the evidence for the benefit of this is limited. So around 6% of all DLBCL patients treated with R-CHOP relapse in the central nervous system. It normally occurs early. Post-treatment, the median time is around 9 months from diagnosis to CNS relapse. That was shown in the Goya trial. And 70 to 80% of CNS relapses involve the brain parenchyma. So isolated leptomeningeal relapses are a minority. So the CNS IPI score can be used to try and predict patients at high risk of CNS relapse. You get 1 point for age above 60 and LDH that's high, performance status above 1, stage 3 or 4 disease or 2 more extranodal sites, or disease in the kidney or adrenal glands. A score of 4 to 6 correlates with a 10% 2-year CNS relapse rates. So the BSH guidelines recommend considering patients with a relapse rate of more than 10% for CNS prophylaxis. So you should be thinking about offering it in a high CNS IPI score of 4 to 6, involvement of 3 or more extranodal sites, or any of these anatomical sites like testicular, renal, adrenal, or intravascular. But since the BSH 2020 guideline, there have been several important papers. So in Blood in 2021, a retrospective review of around 2,000 patients that were high risk had high-dose methotrexate. This didn't reduce the rate of CNS relapse in this large retrospective cohort. The CNS relapse rate was around 9%. Another review of around 580 patients who were treated with intrathecal methotrexate showed a reduction in the CNS relapse rate at around a year, but that difference was lost at 5 years. In 2022, in Blood, a retrospective review of around 1,400 patients receiving high-dose methotrexate, and it was done to evaluate the timing of high-dose methotrexate to be used in between R-CHOP or at the end, but it was noted that CNS relapse rates were about the same in each cohort, especially when less CNS prophylaxis was used. In 2023, the JCO published a retrospective observational study of around 2,000 patients. High-dose methotrexate was not associated with a meaningful reduction in CNS relapse. So the current practice varies in the UK, but CNS prophylaxis is increasingly being reserved for high-risk patients whose disease sites would be things like primary testicular lymphoma, and they would have high-dose intrathecal methotrexate, 12 to 15 milligrams, about 4 times during chemotherapy. Even though it's widely used, it lacks good evidence. It doesn't penetrate the brain parenchyma, which is the majority site of relapse. Therefore, high-dose methotrexate infusions are used with folinic acid rescue. So patients would have 2-3 cycles of that, but they would need good renal function, creatinine clearance of at least above 50, and good cardiac function because of the large fluid volumes with prehydration and posthydration. So certain nuances with the treatment of HIV-associated DLBCL are EPOC has good outcomes, and patients start with low dose of cyclophosphamide based on their CD4 count, and the doses are increased once the CD4 count is above 100. And rituximab can be given once the CD4 count is above 50. Prophylactic antibiotics are needed during the time of neutropenia. Patients do remain on ART during chemotherapy, but the interactions between proteasome inhibitors and vincristine need to be checked with the pharmacy. There is a higher rate of CNS relapse as well. The primary CNS lymphomas are mostly of the ABC subtype with the mutations of CD79B, PD-L1, MYD88 expression on the lymphocyte. It can affect the cranial nerves, and patients can present with symptoms in the eye, as well as photophobia and meningeal involvement, as well as spinal involvement. The diagnosis is obtained with a CNS biopsy, as well as a slit lamp exam to look for optic nerve involvement, as well as testicular ultrasound to check if that was the primary site of the lymphoma. Generally, matrix is used first line for patients eligible for intensive chemotherapy. Generally, CNS penetrating chemotherapy combinations are used, so high-dose methotrexate, rituximab, cytarabine, Thiatepa. More novel agents like ibrutinib, lenalidomide, and PD-1 inhibitors have been thought about, but are generally not currently used in treatment. So in summary, DLBCL is the most common non-Hodgkin's lymphoma. 60 to about 75 patients are cured. Polar R-CHOP improves event-free survival, and R-CHOP therapy is used for most patients. EPOCH-R is used for selected cases in primary B-cell lymphoma, HIV-associated high-grade B-cell lymphoma. You can also think about doing a short course of R-CHOP in early stage disease. You can consider CNS prophylaxis in patients with a relevant CNS IPI score or in certain tumor locations like testicular involvement or intraluminal. But the benefit is not well defined. Thank you for watching, and if there's any comments or corrections to be made, please contact me on blood doc